All right, I'm very pleased to introduce today Karen Clay, who has over 20 years of experience providing support to patients and families facing life-limiting illnesses, including working as a hospice social worker at Providence Hospice of Seattle, a program manager at the Washington Health Foundation, and a clinical social worker on the inpatient palliative care service at Harborview Medical Center. Karen earned her BA in English from Georgia State University and her master's in social work from the University of Washington. She's also a 2015 graduate of the inaugural Cambia UW Palliative Care Training Center. And in the spring of 2017, Karen became the social worker for the UW Memory and Brain Wellness Center's clinic. She's going to talk to us today about a really important topic, optimizing safety and well-being in dementia. Welcome, Karen.
Thank you so much, Barbara. Really appreciate that introduction. I also appreciate that people are here today. I see that there's a lot of folks here and appreciate that this might be sort of the end of the day for a lot of folks. So I just appreciate you prioritizing this important topic. Hopefully this will be helpful for you. Today we're going to be talking about, bear with me for just a second while I move that. Okay, there we go. So we're going to be talking about, so my objectives for today will be to explore quality of life for people with dementia and factors that contribute to well-being. We'll talk about specific, safety risks that are common for people with dementia, and then also discuss strategies to navigate them while also honoring the patient's values. And, my hope is that you come away with something practical to use in your practice, or at least things to sort of think about that you find useful. All right. One of the things that we want to start with is this idea that people with dementia can and do have quality of life. In fact, research has shown that the majority of people rank their quality of life that have early to moderate stage dementia as high. So more than half of people do that in studies. And things that contribute to positive quality of life is management of mood symptoms, the engagement in activities that they enjoy, and ability to do their activities independently. And I think that, one of the things that sometimes happen is that as healthcare workers, especially as a social worker, if there's other social workers here, we tend to sort of get involved when things aren't going well, when people are struggling. And so that's why I think it's so important to really focus on the fact that really, in general, people with memory loss can have good quality of life. So let's sort of think about think a little bit more about what the experts have to say about that. And by experts, I mean the people living with memory loss themselves. This was information that was based on a study that was done a number of years ago, where they put together a cohort of people living with dementia to find out for them about what was important to them. And to the surprise of the researchers, there really wasn't much talk at all about the ways in which the disease was limiting themselves or the frustrations with it. They were much more vocal about how the reactions of the medical community, friends and families were damaging to their well-being than the disease itself. And they did worry about control and autonomy, as a future thing, and also this desire to do advocacy to improve quality of life for themselves or others. Some of the quotes that came out of that I think are really poignant. One of them was that, my doctor just kind of let me loose. You have dementia. There's nothing we can do. Goodbye. Another person said, people just shy away, like a reaction that might be associated with body odor. People didn't even know how to talk to me, even though I was the same person I was 5 minutes before I told them that I had it. It was like I was stupid or couldn't carry on a conversation or have a single thought of my own, which was very distressing to me. So sort of being conscientious of the way that we are treating people that are having memory difficulties is really such an important role for us as healthcare workers and as human beings as well too. One of the things that does come up quite frequently is this unfortunate habit that some healthcare providers do of talking to the person's loved one or family member or friend, whoever came into the clinic with them, rather than the person directly with memory loss themselves. Another thing that came out of this research is that as healthcare workers, we tend to be really focused on physical risks, things like medication errors, nutritions, what happens if there's a cooking accident, falls, hygiene. Whereas the people living with memory loss, they were actually more concerned with sort of like how things would impact them day to day. Would there be a point where driving or finances or something wasn't something that they could do? Also concerns about feeling socially isolated. I feel like that's definitely something that I have seen being exaggerated since the COVID-19 happened, where people just are a lot more isolated and less connected than they used to be. People also worrying about their mental health. And so I think that one of the reasons why I think it's important to talk about this in the context of health of dementia and well-being is this idea that we want to avoid a surplus in safety that is actually harming to our patients. One example of that is I was working with a patient of ours who had primary progressive aphasia, which is a form of dementia. And she had already had a guardian in place. She also had a number of family members that were super involved. They didn't get along with each other, which is why they ended up with a guardian. But the patient was really clear that she wanted to live with her daughter, that her daughter also had grandchildren living there. Her quality of life was tied to being around her grandchildren. But interestingly, the guardian recommended that this person actually be moved to an assisted living facility. And one of the things that she cited was the fact that the daughter's space wasn't wheelchair accessible, even though the patient wasn't wheelchair bound. And so I think that that's a good example of does it make sense, the recommendations that we're doing? We want to avoid, focusing on too much safety such that we're not listening to what matters to the patient. So thinking about what matters, part of the 4 M's of good geriatric care. And I'm not going to be talking about healthcare goals and preferences this time, certainly a very worthy topic. And I definitely defer you to Annie Hirano's presentation last week for more information about that. But I think for our purposes, I'm going to sort of be thinking about, getting to know people and what's important to them, what are their values, and because that can be really important information as we think about increasing the safety for them. So for example, for some people, a high priority is on independence, taking care of yourself. Other people, priority of taking care of my family. I hear a lot about people who are worried about being a burden on my family. Other people, again, especially in the last couple of years, concerned about loneliness, especially since the pandemic happened. Also another concern about, especially in our immigrant populations, folks who have worked hard to establish a home here, wanting to really be protective of intergenerational wealth as a really high value for them to be able to share that with their children. So when we think about what matters for people, these are clues for us that things that we can align with when we're talking about increasing safety. Because we think about safety, we're also thinking about helping our patients, be independent, being able to do the things that they most want to do. I'm going to be talking about quite a bit. I'm going to talk a little bit about a gentleman who I've known for a number of years named Mr. A. And he's somebody who we met for a family conference where he was coming in to have disclosed to him that he had dementia, Alzheimer's. And honestly, at this point, he had was definitely very moderate stage, a little bit, later moderate stage. And when we asked about how things were going, his reaction was like, I'm good. I'm a person who takes care of myself. I go to work every day. I care for my family. And in that situation, the family was like, kind of rolled their eyes and actually disagreed with him in the meeting and said, that's not true. He hasn't worked in 3 years. And, he hasn't accepted that. And we're just really struggling here. And the distress that was in that room was really, really palpable. But the things that we take about around, the things that we can take away from a situation like that, which is also sometimes distressing for us as healthcare providers, is that, sure, this is a family in a lot of distress, patient and their loved ones. I think family could definitely benefit from information to help them learning how to validate Mr. A, avoiding arguing, some basic communication strategies. But it also tells me that Mr. A was extremely proud. He also was really family oriented. And that's something that really was helpful when we're thinking about getting more resources for them. That's really helpful to know. His wife is somebody who also had health issues. So they were living alone and she was not in great physical health, although cognitively she was really sharp. So we want to make sure that we are really thinking about the whole person. And while we want to be getting information from the patients themselves, sometimes interpreting it, we also want to be getting some input for the family so that we are really thinking holistically about any situation. All right. So when we're thinking about things that are risky, I think it's important to first talk about what the situation is, bring it up to the patient and their loved one, explore their values. So for instance, if there's a person with kind of early stage memory loss and this person used to climb mountains and travel the world and live by herself a lot, her sort of risk tolerance is probably going to be a lot higher than somebody maybe who spent their life, as a librarian who enjoyed, tending to her home, things like that. So really exploring what's important to them, connection with family, independence, some combination of those things. And then we want to really make sure that we're empowering the patients in any ways that we can. If somebody is taking over finances, we want to empower them by not just saying like, you are, you have dementia. Therefore, I'm taking away your access to finances. Instead, you would want to approach it as, hey, I'm interested in learning more about your finances. Can you teach me more about it? How about if we do it together? So sort of that ideal situation of including somebody in the care, including some oversight, while maintaining somebody's sort of dignity and sort of comfort with and what's important to them. And that isn't always easy at all. We'll talk about a little bit more about some of those difficult situations, but any opportunities we can to empower people to do the things that they can still do, we want to take. We want to come to some collaborative agreements, like would they agree to a little bit of oversight, still doing things by themselves, but how about having their spouse check over their meds? And then ultimately, having somebody monitoring the results. If somebody is at risk of getting financially exploited, that would be a situation where we want to really tighten things down. All right. So now I'm going to dive into some of the major safety risks that are out there. Truthfully, all of these could easily take up an hour of time going through them. A couple of them could take a day going through them. So I'm going to kind of do my best. In general, I think that, we want to, the ideal situation is to tend to the need before it becomes a crisis situation. So sort of putting as much prevention focused care in place is going to serve everybody well with avoiding crisis and stress and safety issues potentially down the road. So to do that, we want to be sort of focusing on what matters. All right, first up is fall risk. So currently, depending on what study you look at, between a quarter and a third of adults over 65 have a fall annually. And adults with dementia are twice as likely to have falls. In addition to that, people with dementia are more likely to have serious injuries and even death when they do have a fall. Some of the things that lead to increased fall risk, things like unmanaged behavioral disturbance, so a dementia with behavioral disturbance diagnosis, if they have visual spatial issues as part of their dementia, or mobility symptoms, which is really common for a number of dementias, including Lewy body dementia, cortical basal syndrome. Other thing that increase the risk of fall risk is the presence of depressive symptomology. Other things would be urinary incontinence. So people that are already incontinent are more at risk of falls. So are people with fall problems. Another one that I thought was really interesting as a social worker, because it's a place that's easier for me to impact, is caregiver distress is actually associated with an increased fall risk in people with dementia. And so we can actually help decrease risk of falls and therefore injury by also tending to the distress of caregivers. One of the things that was interesting, that I found interesting from doing the research for today, was that actually fear of falling is actually something that a lot of people are embarrassed to talk about. And so it's important for, as healthcare workers, to know that even if they are at risk, that may not feel comfortable bringing it up. So making sure that we're asking is important. All right, so actions that we can do to help people with dementia. I certainly defer to reviewing medications, correcting vision and hearing problems, vitamin deficiencies, to the medical providers as the experts. For other things like providing strength, balance, cognitive training, and other ways to decrease this distress in the home, that's definitely something that anybody working in the field can probably help with. So thinking about, how to align with this. So for instance, if you're worried about a person falling and you know that they are, very focused on their own independence, then calling out, studies show that you've got a high risk of falling and a high risk of falls, and you have a much better chance staying in your home for longer if we can do these preventative measures to decrease your fall risk. Also, lost my train of thought there. Also for people who are having, issues of loneliness or connection, knowing that there's resources out there that can also impact that need of wanting to connect with more people can also potentially decrease their fall risk. An example of that would be, taking a fall prevention class, which is offered in a lot of places. Most counties in Washington state have access to them, or most regions do. So connecting with your local area agency aging or senior center for classes or programs that focus on strength and balance, things like that can be really helpful. The Alzheimer's Association is also a great place to find out about other, classes and programs happening in that area, as well as for things like caregiver training classes to decrease the distress for the caregivers. And again, decreasing the stress of caregivers can improve the safety for people in their homes. Doing this research, I found a couple of great publications that are out there. From this, I think it's the study program. These are free documents that are available that can be downloaded. Here's a couple of them. I'm also including these in the resource section of my presentation. All right, medication management. So medication management is also one of those areas that is really important, because the risk of making a medication error can really be dire. And again, we want to focus around what's important. So when we think about medications management, so sort of like trying to get buy-in for tools that are available to help with that process. And things would be, if you're taking your medication right, that could be associated with clearer thinking, improved mood. Again, those sort of like depressive symptoms can lead to falls and other independence. So again, we want to start early and utilizing the memory medication management aids. Excuse me. So these are, when we think about medication management aids, these are some of the ones that are available. And I was talking to Dr. Brock Gaster, who is a physician through the University of Washington primary care system. And his opinion is everybody needs a MediSet. Doesn't matter, if they're taking any medicines or vitamins, doesn't matter how old they are, if they're cognitively impaired or not, but really we all need to be using MediSets because it's just so easy to forget that we've taken our medicines or skip a dose. And so I think getting our folks all to get in the habit of using a MediSet is something that really serves everybody well. And again, sort of focusing on good habits initially. I think I'll also think, before I move on, I want to talk about the fact that there's actually, ideally for somebody with memory loss, the idea is that initially there's oversight, so can you and your care partner, spouse, child, if they're living there, say how about if we fill our MediSets together? How about if we take them together? If the person with dementia is still able to do that themselves, letting them do that with a little bit of oversight. And then sort of working up towards sort of taking over full management as things change. There are a couple of other medication management services. So this photo is from PillPack, which is the middle photo is a pharmacy service where things come in a little pack. And those work okay if you're somebody who is able to track the day well, and that you're not having a lot of medication changes, and that you don't have extra things like inhalers and things like that. Related to smart MediSets, in general, they're really hard for the average person to use successfully. So I think that some of the folks, even our neuropsychologist, said she tried to use one herself, and it was just so complicated, and she ended up kind of mixing up her medications. So I do think that in most circumstances, sort of the classic MediSet with oversight is the best way to go, if at all possible. The one example for me that I saw where things were working well is I had a family that I had been working with, a patient with kind of moderate dementia who was living alone and doing okay with it. And this was a family who had resources and actually had a paid care manager that was able to go over there, set up the MediSet. It was one that would set up so that each time they're supposed to take a medicine, a little door would pop up and tell the person to take it. So again, in my many years here at the center, there's only been that one experience where I had somebody say that they were using that and it was working really well. So that can be a complicated one. All right, so now I'm going to jump into even more complicated situation. This is the issue of home safety. This is from a study from the AARP about home safety and senior preferences. Their study, which I think was really highly Western focused, showed that folks had a really high value on independence and autonomy. And 3/4 of people prefer to remain in their current residence as they age. And I think that, truthfully, I think that there is also still a lot of stigma out there about residential care, and also like having somebody come in. But when I think about residential care, a lot of people that are older now, their experiences with sort of nursing homes was potentially visiting their parents when they were younger. And they were places that were, true nursing homes where people would be kind of lined up in the hallways, not engaged, not very active. And I think that the way that we think about long-term care has made some progress since then, but a lot of people are still sort of thinking about residential care means going to a place where I'm just sitting there ignored, that smells bad and drooling. And so really doing a little bit about reframing about actually a lot of these senior housing places, offer activities, offer opportunity to socialize and games, depending on the place, even field trips out to the casino or out for hikes or things like that. So, again, sort of we want to be thinking early on about, how can we start laying the seeds for accepting additional care as things go along. When I think about, there's a patient that I've worked with for quite some time now. I'm going to call her Mrs. J. And she's somebody who the first time I met her, she was like a real spitfire and was like, hi, how are you? I'm the social worker here. She was very much, I don't need you. I appreciate you. I'm doing fine. I do everything by myself. I'm even thinking about taking on students for piano lessons again. So again, super high insight. And again, super high value on independence and autonomy. This is a nice quote that I like from Maya Angelou. The ache for home lies in all of us, the safe place where we can go, where we are not questioned. My reaction in general is that, of course, people want to be in their own place. That sort of like connects with that value, that sort of symbolic home, a place where we are understood, where we're safe, where we're with people that are, that love us, has that sort of idea about home. Recognizing that, not everybody has had that in their life, but often that is sort of the ideal about what home is when they're thinking about home. It is interesting that, as most folks know too, it's pretty common for people with memory loss to actually say that they want to go home, even if that they're in their home that they've lived in for a very long time. And I think that is sort of that connection to that desire for that place where we can go, where we're not questioned, where we're accepted for who we are, where we're loved and known. Definitely understandable. So this is a question that I get a lot as a social worker here, although almost exclusively from care partners. I think in my years here at the Memory and Brain Wellness Center, as well as at hospice, I think I only had one person to say that sort of asked me, how do I know if I'm safe to be alone? So this is a list of some of the general ideas. So the first one, sort of, ability to respond appropriately to safety. That would be, if there's a fire, can they get themselves to safety and call 911 successfully? Another issue is, are they leaving home and inappropriately having difficulty getting back home? Are they using power tools or climbing up ladders? Before I worked at the Harborview inpatient service, I didn't actually realize how many older folks are getting up on ladders and unfortunately falling down. So sort of are they engaging in dangerous behaviors? That would also be leaving a stove on. It's another potentially dangerous behavior. And then another one to talk about is sort of this anxiety or fearfulness when alone. And, in first glance, you might think, oh, that sounds easy. If they're anxious about being alone or fearful when alone, they're probably going to not want to be there. But more likely what that looks like is that I'm doing fine where I am, but people are breaking into my place and I just need them to stop. So sort of it's not me that's the issue. It's that something else is happening that's making me unsafe. And if I could take care of that, then everything would be okay. So sort of anxiety when left alone. And even if it's not something that is, even if somebody isn't breaking in. So, in general, the best place for a person with dementia is one that helps them feel as independent and supportive as possible. And we really want to be seeking to find a balance between those two as we try to serve our folks well. This is a quote from Dr. Personaire, who is a neurologist at our center. And, this idea that our society takes protections of personal freedom very seriously, and there's a good and a bad side to this. So what happens when the person who is living by themselves has declining executive function and their status decline? It can be really hard to know sort of when have they crossed that over. And it's also something that, our laws are such that in our society, we really value independence. And it's a very, very high bar for somebody to be removed from their home. We had worked with some, I worked with a guardian who had somebody who um, uh, was working with somebody was very marginally living at home, and she was living at home because her neighbors were really propping her up, or sort of like doing their best to take care of her, in another way to think about that. And, things were not doing well. She was losing weight. She had some falls. She had multiple missing incidents. But the guardian's perspective is that, until the patient was agreeable to moving, that she wasn't able to move her unless she ended up being in a hospital, or else people kind of removed some of the support that they were doing. And that doesn't feel good at all. Like there isn't an easy solution to that. Thinking about Mrs. J, who I talked a little bit earlier, who I met, and she was just, so staunchly independent when I met her. She was really needing increasing help. Fortunately, she had neighbors that were doing their best to take care of her. Her friend, fortunately, she had identified somebody who was a power of attorney already, so they were able to put some things in place. But she was having difficulty with meals, difficulty using her phone. She started thinking her phone was broken, and she was able to buy other ones. So really at loose and stop paying her bills. So getting into some serious financial trouble. She also started to refuse her meds when they came. She smashed them with a hammer. And she started feeding raccoons. And, neighbors started being really concerned about her. Whereas Miss J remains staunchly, I'm doing great as I am. Thank you very much. I don't need any help. And these are really often, ethical issues that come up with us. These are issues that bring a lot of distress to us. I myself utilize supervision a lot to sort of talk through these things, consult with other team members. I think that also knowing about other community resources for other people too, like the Alzheimer's Association, and we'll talk a little bit more about other ways to support people that are having a lot of difficulty. So as people's needs are changing, again, we want to, ideally be in a situation where we've talked about what their hopes are and we've got those things in place. But I also understand that isn't realistic for a number of reasons. Sometimes we just don't get to meet people until they're already in crisis. But recognizing that there's oftentimes a lot of support or resources out there. So checking in with the patients, like, can you have somebody come to visits with you? Who are your people? Are there, volunteers that you might connect with? Are you connected with a religious or spiritual community? There are also programs for people who are financially eligible through Medicaid or long-term care programs. Adult day health programs are available in some parts of our region. Technology sometimes helps. So the good news is that you don't have to be the expert in all of those things. If you don't know what those resources are, then getting to know who your local area agency on aging is a really great number to have at hand, so that if you've got somebody that's looking for, care programs in that area, somebody to help them understand if they qualify for Medicaid, is there transportation available? That's your go-to place. Every county in the United States does have an area agency on aging. And if you're not sure what yours is, you can literally Google the county that you're in, area agency on aging, and it'll get you the connection with your local group. The Alzheimer's Association is another great, if you're not a social worker yourself or need somebody to kind of help understand what the resources are. The Alzheimer's Association does have a 24-hour helpline with master's level social workers and counselors available. Other resources, so these are your general resources, but also thinking about, how to negotiate with the people that we talk about with safety issues related to what's important to them. So for people who are worried about being a burden on their family, sometimes if they are staunch that they don't need support, but they really don't want to be a burden on their family, sometimes framing things around it's okay if it's fine if you don't need a report or you're okay. It seems like you're doing okay, but it seems like your family member would, who you're worried about being a burden on, actually worries about you a lot, and that would help them feel better. So that idea about sort of like getting a little bit more support in a way that resonates with like, oh, I'm actually helping my daughter by getting this help and getting this in place. Thinking about, instead of having, the word caregiver is also a little bit stressful for people, or triggering for people. There's a lot of stigma with that. And I think it's fine to sort of say, how about if we start with a companion? How about if we start with, for some of my folks that have been, in business before, sort of saying like, hey, how about an assistant for your place? You've worked hard during your life, and you deserve an assistant. A lot of people are getting assistants, so sort of trying to normalize for other people too. So we're, again, not saying, you need help because you can't take care of yourself. When we say things like that, most people would say like, you don't know what you're talking about. It can bring up anger, it can bring up shame, and it rarely leads to somebody saying like, oh gosh, I think you're right, I'm going to go ahead and try it. So again, thinking about what values are there that you can align with as a way to help decrease safety concerns and increase quality of life. But this idea that, for a lot of people that they're having loneliness, even if they're living alone, they may, enjoy the companionship of being in a facility where there's other people. Again, it depends on what's important to the person living with dementia about, what value it is that we can sort of meet by and hopefully at the same time decreasing the risk. Thinking about Mr. J, or Mr. A, who is the gentleman who was at the family conference and was like, I don't have dementia, I work every day. For this gentleman and family, we spent a lot of time kind of working with the family about how to better support him, how to, the benefits of avoiding arguing, sort of going with the flow, thinking about the fact that he's actually somebody who really enjoys, giving to his family. So we sort of talked to the family about how can you help him, how can you help feed that sense of like, I am helping my family, by sharing his wisdom, asking more questions about how, he thinks about things, asking for his help, sort of finding those meaningful things that he can do, because we know that that's a really important value for him. Another thing that worked well for him is that he is somebody who qualified for our state's Medicaid long-term care program. And while his wife also needed help, his daughter is somebody who was able to become his paid caregiver. And so it ended up having the sort of the happy ending that Mr. A was able to spend more time with his daughter, who is getting paid as a caregiver to be his support. And then she was able to provide extra companionship, and then again, really worked on sort of interacting with him in ways that felt meaningful to him. Related to our other patient, Mrs. J, who was the one who was just really staunchly independent and started having really dangerous behaviors, like, using a knife to open letters. She's somebody who had a small rental property, and she forgot that she had rented it out to a young family. And then she thought that they were squatting in her property, and things escalated to the point where she started to really kind of harass them. And in one circumstance, she actually started to be physically aggressive with him. And so that was a point where initially calling 988, which is now a national crisis helpline, where you can call 988. If there's not an acute emergency, it's a good place to sort of like get advice, to sort of like say, hey, this isn't really going well. I'm not about to be, hit with, weapon, but I'm sort of noticing that my neighbor is pretty agitated. Then that's a 988 call. When things are really intense, so when she started physically trying to attack somebody, then that is a 911 call. And for Mrs. J, she, after multiple calls to 911, eventually was taken to in for inpatient psychiatric care for stabilization. She was then discharged without a safety plan in place, continue to have behavioral issues. I advised everybody who was calling me saying like, hey, I'm really worried about this person. Like, you need to call Adult Protective Services to report that. And when there's a risk of immediate harm, to please call 911. And eventually she was put into geriatric care again for inpatient psych hospitalization, and is now living in an adult family home. She discharged from there and is actually coping pretty well because she is getting good medication management. Even though she talks about wanting to go home, the perception of her is that she seems a lot less agitated, a lot less distressed. And, she actively engages in other activities that are happening at the place. So I'm also going to touch base on wandering, which is another potentially really dangerous activity that sometimes happens for people with dementia. And, this is a really, serious issue, and I spend a lot of time with it. I think that one of the things that's really important to realize is that there are many reasons that people might wander. And it's so important to understand what the reason is so that we're able to offer the right thing. The wrong thing would be to have everybody who is wandering be locked in a locked memory care unit. That would be terrible. So for example, restlessness is something that we see a lot, especially for folks that are younger onset, folks that are able-bodied, but are having more difficulties cognitively. Sometimes, there's just this need to sort of move and get out. And so making sure people who have that restlessness have that opportunity to get that energy out. Are there people that can go for walks for them? Are there, volunteers or neighbors to just make sure that they're getting that physical exercise? Boredom is another reason that sometimes bored. So is the person with dementia having enough of those meaningful activities that are that throughout their day? Are they having structure? And that's one of the things that can decrease wandering. Thinking about, does the person, sorry about that. Making sure that person's basic needs are met. Have they, do they have to go to the bathroom? Are they hungry? Sometimes wandering is a sign that somebody is having some delirium, maybe an infection. Sometimes, like Mr. J, he is somebody who had a couple of wandering incidents where he would wake up at his usual time where he used to work a number of years ago, thinking he had to go to work. So sort of like that sort of sense that he's following past routines is something that put him at risk of wandering, and actually did happen a couple of times. So strategies to decrease wandering. One of the first things to really focus on is the fact that if there is somebody who has left home or gotten lost, that's important to advise people to not spend very much time looking for them at all. So I'd say less than 15 minutes before you call 911 and report that a person with dementia is missing. The longer we go without finding them, the less likely we are to find them safely. So being able to catch them when they're close by can really make a difference. Also, I've heard that people tend to turn towards their dominant hand. So if you've got somebody who is a left-handed person, then more likely if they're going out and are given an option on which way to go, more likely to turn left. So sort of thinking about that if you're having to look for somebody who is missing. So again, the management of wandering depends on the cause of wandering. And so again, thinking about the holistic person, for people who are restless, making sure that they have enough exercise. For Mr. A, who was still thinking he was still working, his wife, instead of telling him to just, go back to bed, he doesn't work anymore, instead started saying to him, oh, honey, you've worked hard. This is your vacation, this is your weekend. You don't have to work today. come back here and we're going to relax for a little bit. So just sort of changing the way that family members were interacting with him really decreased the distress in the family. Again, this idea about making sure that people with dementia have that meaningful engagement, so that they're not bored. It is also something that you want to avoid visual reminders for people that are at risk of wandering away. So things like keys, umbrellas, coats. If somebody is sort of triggered by those to leaving, then those could be removed. When somebody is having incidents of getting lost or separating, that can be a sign that they need more supervision. And working with family members to figure out a plan for supervision can really be helpful. Again, one of the signs that somebody might need to have a caregiver. And again, connecting with those resources to, so that they can help keep their loved ones safe. We do recommend people with dementia to have a medical ID. And recommending that, I think, is a good idea. Normalizing for people that this is something that a lot of people wear. Sometimes if people are sensitive to it, a person's care partner will also get one that says like, hey, I'm a care partner for somebody who has dementia, so that in case something were to happen to them too, it would also alert a designated person that a person with dementia also needs to get that oversight. Technology resources. This is a tricky one because technology is changing so fast. And generally speaking, there isn't a perfect technological answer to most issues. When you think about things like, phone apps, GPS trackers, even smartwatches, a lot of them are dependent on the person being able to keep track of something, things like shoe inserts that they only work if the person is wearing that size shoes. Phone apps with GPS only work if the person carries their phone with them. There are, especially for people that are early stage, that they can be really, really helpful. Things like GeoBit and Tiles are also things that we have a lot of experience for people that feel like it's been really helpful to them. Keep in mind that AirTags is actually something that's not recommended. AirTags is a different type of technology which requires you to be near other people with iPhones. And it doesn't also always update as to the time where you are. So it might be that your update about your timing, sort of that ping to the other device, only happens after 30 minutes or an hour, sometimes even longer than that, which would be, too long potentially for a person to be missing. So keep that in mind with the AirTags. When it comes to the medical alert systems, it's very common for people to not remember that they are wearing one if they have dementia. So people, even relatively early moderate stages, sometimes they are in a situation where they've been on the ground for a long time and they just didn't know that they were wearing a button. I will say that some of the ones that have that fall detection system can be a really great help to family members, especially if the loved one is living alone. A lot of the newest version of the smartwatches also have those on them. The National Council on Older Americans or on aging also produces a regular publication that reviews some of the products that are out there. So that's a place to check in. All right. Diving in dementia, certainly something that is a big issue, and we could spend a lot of time on it. One of the very important points about dementia is to really appreciate the ways in which dementia is a part of our identity for many of us in the United States, especially our older generation, folks of that greatest generation, or some of the baby boomers, sort of growing up with this idea about sort of like, quality of life is an open road, driving through the sunset. And so loss of driving privileges is actually a huge blow to people's identity. And so we want to be, thoughtful about that. We don't want to be removing that identity before we need to, because it has such a big impact on their identity and also potentially their ability to connect with other resources, those other meaningful activities that, help keep them, sharp and have good quality of life. Having said that, we do know that everybody with a progressive neurodegenerative dementia is going to get to a point where they're no longer safe to drive. And unfortunately, there still isn't one way to determine whether or not, yep, you've crossed that line, you're no longer safe to drive. There are some cognitive tests that are more correlated with safety in driving, but it can be really hard to know when a person crosses that line. Certainly people in late stage dementia should not have access to the car, and really most people in moderate stage dementia should also not be having driving privileges. So some of the things that are helpful to know would be helping family members and people with dementia recognize there's warning signs that they're no longer safe to drive. Are there unexplained dents in the car? Are people noticing that their loved one is driving either too fast or too slow? Are there situations where they're just a lot more irritated or aggressive or agitated than is typical for them? For people with memory loss themselves, like, have they noticed that other people are honking around them? They're not sure why, but I've noticed that a lot more people are honking at me. Might be a sign that, a warning sign that we might be having more difficulty. Any inattention to traffic signs, difficulty staying in the lane. A couple of important things to know, that if there is ever a situation where somebody has confusion of gas or brake pedal, like that is like a hard stop, no longer safe to drive. Same thing for people who just are driving along and then stop in traffic for no reason. So when we think about strategies for dementia and driving, again, the best thing that we can do for all of us would be to sort of be talking about our families before we have issues. Ideally, setting down a contract. I know the Alzheimer's Association has a driving contract. So does the Hartford Insurance Group, that sort of says, like, I'm in my right mind now, but if I'm ever told by a medical provider that I'm not safe to drive, then I want you to take the keys away from me. So sort of giving loved ones permission in the future to remove my driving privileges, even if I don't have the insight that I'm safe. I think it's a great idea. I haven't seen as many people that have done that and found it was successful. I like the idea of talking about things early, trying to put things in place to make it easier. Other things that we can do would be talking about transportation options. This really depends on where you are. Certainly people that live in an urban environment have a lot more transportation options through, their local senior center. Uber, Lyft is ready, available. Usually people don't have as far to go, whereas people in rural areas, sometimes rural areas have more transportation volunteers available for elders. It's certainly something to look out. And that would be a reason to call your local agency on aging to say, like, hey, let us know if there's any transportation options, because we want to keep this guy active, doing things that he loves without driving. As much as we can sort of normalize, like, hey, we're all sort of trying to get away from driving. It's so stressful to drive nowadays. Parking is expensive. So there might be ways that we can sort of start, setting the stage about, the idea that eventually it would be okay to give up driving. We utilize the words retiring from driving. I think that we hope that that's a little bit less stressful or triggering for people, rather than sort of revoking somebody's driving privileges. I guess just thinking about, the language that we use to be respectful and less triggering for our folks. When we think about dementia and driving, when there are issues, sometimes family members don't want to be the one that's the bad guy. So as healthcare providers, we can sometimes be the one who is the one that's saying, okay, it's time for you to drive, and even making a report to the Department of Licensing if that's something that's warranted. However, reports to Department of Licensing isn't at all a guarantee that your loved one is going to stop driving. People with dementia that are reported to the Department of Driver's License, number one, may not believe it. Number two, may literally just not be able to hold that information, and so just completely forget. So having somebody's driver's license revoked isn't at all a way to safeguard that somebody isn't protecting. However, sometimes, having somebody in authority or a piece of paper that says, like, look, you can't drive. For some people, that is a way that helps them resonate. If there's somebody who really, appreciates rules or appreciates authority, that sort of written thing can be something that sort of resonates with them, keeps them safer. Last resort options are things like removing keys, disabling car, saying something like the car is at a shop. Again, like, because of the fact that, driving safety, can have such a big impact, not only on the person that has dementia, but also other people in the community that could be injured by that. I think that those sort of last resort options can be really important. Some driving safety resources. I alluded to earlier this publication from the Hartford Group, which is kind of a free publication that has warning signs about driving safety in it. Also has that list of, has a form for if you want to do a driving contract, and also just sort of helps talk through with families about how thorny this can be. Again, having people start using alternative transportation options as a way to sort of get used to that, sort of pave the way for, eventually being able to retire from a car, serves them well. There are also public disability transportation programs in each county. Through our center, we do rely on certified driving specialists for when people want to have a driving evaluation. If we have concerns about their driving and the person is not at all willing to retire. The challenge for this is that this is not something that insurance pays, and the price in most of this Washington area is over $650. There's a program over in Spokane, Washington, that's a little bit less expensive. And I don't know about other states too, but in general, this is something that is not covered by insurance, is not covered by Medicare, and so it's out of pocket. And so that really does bring up issues for a lot of our folks that are on limited income. All right, now we're going to jump right into another, very important issue. Again, I think that it would be really interesting to spend an hour on this or more. I think that one of the things to understand is that about 40% of households, there's a gun in the home. About 30% of adults are gun owners. And there are, very diverse in terms of age, gender, race, ethnicity, and cultural background. Reasons for gun ownership are really varied. Some people for hunting, for sport. Some people, it's a very important part of that protection of the family, protection of myself. And so understanding why, what the value is of the firearm is really important to be able to provide care and to be able to address what the safety issues are. So Harborview has some great resources through the Injury Prevention and Research Center. And again, they have a special program or special resources related to safety for people with dementia. And, certainly safety is a major concern for people with dementia. They're at increased risk of injury due to problems with memory, judgment, and mood. So they're increased injury for harm to themselves as well as other people. It's also helpful to know or important to know that firearms are the most common and deadly mechanism for suicide in older adults. And recent studies have shown that persons with dementia are at increased risk of suicide, especially soon after their dementia diagnosis. When we think about, firearm use, I worked with a family whose the person had, very much valued their firearms, always very responsible with his firearms, always had them locked up. And then he started having some cognitive difficulties that included worrying about other people coming in. And so in his mind, he had, he felt like there were some safety threats. And so he became convinced that he needed to have his gun with him. And so instead of his pre-dementia self would have, recognized that it's not really safe to sleep with your firearm next to your bed when you have cognitive difficulties. For him, he was just like, I want to protect myself, my home, and my spouse from it. And so his spouse tried to sort of negotiate with him, like, hey, how about if we, just, keep it locked up, know where it is, move the locker into the room a little bit. And he was like, the only consolation that he was willing to do was to actually point the gun away from them when they slept rather than towards them. And one morning they woke up and the firearm was actually under the pillow. Neither one of them knew what happened. And that was the trigger for the wife to say, like, that's it for me. We have to do something a little bit more drastic here. And in this particular situation, she talked with him a lot about sort of, why things were important. She understood that for him, but the risk had gotten so much that she ended up having a family member come over and remove the guns from him with just the, basically saying, like, we have to do this because his wife was just really worried about her safety and others, because he was really having a lot of confusion. He was started to have some hallucinations that people were breaking in. And she was just so worried that she would be, going to the bathroom, coming back, and he might mistake her as an intruder. Studies have shown that people who own firearms are open to talking about it with a healthcare provider when it's associated with a specific safety concern. And so not as in sort of, I think a lot of people are very, that's something that's very private for them and not something that people just talk about, very casually necessarily. But I think as healthcare providers, we're in that role of potentially, having that reason to check in with safety, especially that we know that people that are having, cognitive difficulties, physical difficulties, or emotional difficulties are really at risk for serious injury from firearms. So talking about firearms in the context of safety and include other issues with it, so ideally not sort of coming in guns blazing initially was sort of like, you've got dementia now, let's take away your firearms, but instead sort of that understanding about, why these are important. If the issue is related to, fear of safety or wanting to protect somebody, is there information there that you can talk about, like, well, how can we help you feel more safe without having immediate access to the firearm? Talking about a plan for firearms is helpful. These are some resources that are also available, as we mentioned earlier, related to home safety issues. The National Suicide Prevention Lifeline is also sort of 988. That's available no matter where you live to talk to somebody who is trained in crisis support. I'm going to talk a little bit about this great resource called the Firearm Life Plan. This is created by the folks through University of Colorado in conjunction with the Rocky Mountain VA with funding through the National Institutes of Aging. And again, like, ideally, these are things that people are thinking about reading and utilizing before they have a dementia diagnosis. This is a publication that talks about the warning signs very explicitly, about the physical issues, cognitive issues, behavioral and emotional issues that can make it unsafe to operate a firearm safely. It's really respectful. This was created with a lot of work with people who are enthusiastic gun owners. So I think it's very respectful language. This is a resource that's available for free to download. And I did put a link to this in my list of resources. It also has things like scripts for people to talk about the issue of gun safety. I'm somebody who loves scripts, to sort of like help people think through how to bring up the topic. They've got scripts both from the person with dementias, from the person who's a gun owner's perspective, that idea of like talking to your family, like, I understand as I get older, some things might change. It might be a good idea for me to have a plan in place for what might happen to my firearms. Versus family members, things like, I know it's hard to kind of normalizing that we know that this is a hard thing to talk about, but it's important. I've noticed some changes. Would it be okay if I went to the range with you next time you go? So I had some specific wording for people to utilize. The firearm safety plan also has a place where you can list the firearms, and then another section about sort of the legacy, like, what do these firearms mean to me? Where did they come from? What is my hope for what would happen to them when I go? Is this something that I want to have as a legacy for family members, or do you have some other plan about it? So really kind of walks people through what they can do, what some of the issues are about safety, and what's a plan in place for when there's no longer the confidence that somebody can manage them safely. All right. So thinking about other issues related to gun safety. So this is the 2023 list about states that have red flag laws. So in our Northwest region, Washington and Oregon are the only states with red flag laws on the book. Montana and North Dakota do have some proposed ones too. So for the folks in both in Washington and Oregon, sort of thinking about what does that mean? So in Washington and Oregon, we both have it. We refer to it as an extreme risk order. And what an extreme risk protection order, or a ERPO, does, it basically allows a family member or a law enforcement person to restrict gun possession when there's a risk of harm. So for somebody who, like the family that I talked about, where he insisted on sleeping with a gun under his gun on his nightstand, this is an option for them. Would have been for the wife to contact law enforcement to say, my husband has a significant dementia diagnosis, and we're really worried because he isn't able to operate them safely. And then the judge would make a determination, ideally in that, oftentimes in that same day, where potentially a law enforcement officer would come to the house to physically remove from the guns from the home. When that's a circumstance, the guns are removed. There is a final hearing date in the future where the gun owner can sort of challenge that order. This is a way for people to more quickly remove access to guns for people when they seem at high risk of having of not being able to manage gun safety. And this is in effect for 1 year. In Washington State, oops, I'm kind of getting ahead of myself here, sorry. In Washington State, we also have a program called the Safe Storage, where people are able to take their guns to designated places and basically turn them in temporarily. So not completely giving up their guns, but say like, hey, can you keep our guns safe for us while we're dealing with this health emergency? And sorry. So can you take our guns for us and save them there? So I did have information on the list of resources that I have with places that you can go to find out if there's one near you. So again, this is a Washington state law. We also have a voluntary waiver of firearm rights so that you can voluntarily let law enforcement know that you don't want to have a gun. And that's a temporary one to say that you could, if you get on this list, then it would mean that if you tried to buy a gun sort of impulsively, then you wouldn't be able to because you're shown as having restricted. And that's something that's a voluntary program too, that can be lifted, but a way to sort of like, if you're worried about depression, that you can sort of put a temporary hold on it while you're managing your issues. Okay. So now we'll talk a little bit about resources. This is a great resource. It was created by the Washington Dementia Action Collaborative. It's called the Safety Info Kit, and it talks about issues related to wandering, risk of exploitation, and has links to home safety resources, things like that. We also have the Dementia Roadmap, which is a free guide for families and care partners. Again, the Alzheimer's Association 24-hour helpline is a great resource if you're trying to connect people with resources or want to problem solve, like, how do I respond to this situation? All right. Here are some of the other resources that I talked about in this presentation and are included in the resource list that I put together. All right.
Thank you so much, Karen. We've had some questions and helpful, interesting comments come along during your presentation, and so I thought I'd get started on that, if that's
Absolutely.
all right. This was just great. What a comprehensive perspective. I can imagine it was a challenge to put all of this together. It was pretty impressive.
Yeah. I appreciate your kindness with that too.
So Lorraine had mentioned earlier on that she understands the family and carers the issue about damaging well-being. I see this with healthcare workers in the nursing home, never giving people agency and control over the things that people are interested in. These are the things that the person can easily make decisions and take control over. It's painful to see. Families do the same. The fear of injury by falling is over the top. You can fall anywhere, even in a care setting. I wonder if you have anything more to add to that.
Yeah, gosh, I think that's a really good point, and that unfortunately a sad observation about how a lot of people could really benefit from more, support and education about, how to support quality of well-being. I think that, part of what you're bringing up are basic issues of respect and dignity. I think that I'm sorry. Would you mind, Barbara, just reminding me the last part of the question?
So it was about the fact that families are really worried about falling and the injury and that sort of thing, and yet that actually can happen anywhere.
Yes. Thank you. Appreciate that. Yeah, I do think like one of the things that is important to know is that sometimes falls happen in spite of everybody's best intentions. We want to do what we can to reduce the risk of falling, but we also should maybe explain to people that in spite of our best efforts, sometimes people fall. The alternative would be to lock somebody up in a padded cell. That may prevent them from an injury fall, but we can appreciate that that is not, quality of life standard by most everybody's standards. And so sort of normalizing that in spite of our best efforts, falls sometimes happen. And I think it's important to talk about that too sometimes because of the fact that a lot of family members have a lot of guilt associated with that. Had I just done something differently? So I think if we're, maybe saying like, we're going to do our best to reduce risk, sometimes accidents happen, accidents happen to all of us. And we're doing our best. We appreciate that you're doing your best to, balance that, quality of life with falls. And, again, falls cannot be 100% prevented. And so sort of being, for the loved ones who are feeling guilty, trying to sort of say like, you know what, we did our best to, mitigate falls, and think about that and advocate for our loved ones who are in facilities. But sometimes falls happen in spite of our best efforts.
So then, on the topic of the meds, Andreas, I hope I'm pronouncing that right, mentioned the problem I have with these Medisets is many of my veterans cannot fill it. Also, some of them are on 20 meds that they take 5 times a day. Someone from the VA mentioned that you could also put in for a home health nurse to come in and do the medication trays. I don't think they do it for long term, but it would be a start. Do you have any thoughts about that issue with medication administration and getting the meds set up and ready so that they can be used safely?
Yeah. Well, I guess one of the questions I have would be, do they have if they don't have a loved one to do it, that's sort of managing meds, can they go to a pharmacy? Is there a pharmacy locally that would be willing to fill up a Mediset for them, as a potential option for them? Again, I think it's really tricky. And again, it is sort of one of those things that could be a sign that somebody needs more assistance, if they're not able to manage their meds. Um,
And Mary Lou mentioned people still have to actually take the meds that have been set up and may
yeah,
not be reliable in following through on that.
yeah, that's right. And I do think that most caregivers, so if you have a state caregiver, if you're on the COPES program, then, most caregivers, or I should say all like CNA level caregivers, like being able to fill in Mediset is not something that they're going to be able to do. Um,
And Andres mentioned, unfortunately, the VA pharmacy does not do blister packs in Spokane, so that's an issue.
okay.
Related to driving, Andreas mentioned I worked with a woman who agreed to give away her car as she realized it was unsafe. As she denied mentally, this became a huge issue, or declined mentally, sorry. There were accusations of theft, calls to the police with reports of stolen vehicles. I'm not sure if you've had experience with that issue of agreeing to give up the car, but then also having that mental decline that creates all kinds of issues, including reports of stolen vehicles and that sort of thing.
Oh, yes. Oh, yes. Really common, really complicated. I do think, as I mentioned, that, even doing a report to the Department of Licensing to remove your license, is not an effective way to get somebody that doesn't have insight about their situation, to stop driving. I do think like family actually needs to, or somebody needs to take the action of removing access to the car, whether or not it's moving the car away, stealing the car keys, disabling the car. When there's a situation where somebody should clearly not be driving, and one of those systems fails, it's actually appropriate to call 911 and report that somebody who, has dementia, again, you want to say like, this is a person who has a medical condition and they are not able to drive. They shouldn't be driving. The doctor has said that they shouldn't be able to driving and they're driving. This is where they're going. That's the responsible thing to do for sort of the
And Mary
society.
Lou mentioned a person can have driving assessments done by OTs with multiple evals. It's fairly thorough. They can make a recommendation about driving retirement or certain restrictions. And then there was a discussion about Uber and that kind of thing. Linda had mentioned that occupational therapists can evaluate and test if his driver is safe, but there was some discussion about whether or not that's the comprehensive issues about driving are covered in a clinic assessment rather than that assessment happening behind the wheel. I don't know if you have comments about who can, should,
Hmm.
does make those
Hmm.
kinds of assessments.
Yeah, absolutely. I mean, I think this is a common thing that we've talked about a lot in our clinic. And some of it is, dependent on the situation. In general, through our center, we want to aim for the gold standard, which is a driving evaluation with one of those people who have that certified driving rehabilitation specialist, which is sort of extra credentials. Interestingly, not all of them are OT. Some of them are speech therapists or physical therapists. But again, that's sort of the only folks that are doing the on the road piece of that are oftentimes those people that have that extra specialty. And I think that there's a worry that sort of I do think that it is true that there is correlation between some of the things that you're testing for. Certainly if somebody isn't, able to multitask, has slow reactions, is not able to sort of like maintain focus. It's kind of an easy, should not be driving. A lot, that one of the problems is that people that have dementia will sometimes say like, how could they say that? They never even saw me drive.
Yeah.
And so that's just, I do think, although for people, given that on the road driving test is so extraordinarily expensive, does it make sense to sometimes say like, okay, why don't you try occupational therapist? If you pass that, then let's have a conversation again too. I feel like a lot of those OT therapists, they actually do, a good job. I feel like a lot of people do fail. I feel like a lot of folks that have gone to them have failed their test too. So I think that, they do a good job of screening when people have those issues. The issue can be whether or not people are sort of believing it. And again, like we don't have a lot of great data about, when somebody is no longer safe to drive.
And then on to another focus. Linda had asked if you could speak a little bit more about GoGo Grandparent. She didn't find it in the App Store.
Oh, sure. GoGo Grandparent is an app similar to Uber and Lyft. And it usually uses, I think it's currently using Lyft as a base. It should be an app. I think I've seen it before. You can certainly Google it and see their website. The way that works is it's a way to sort of make it easier for people who can't use a smartphone. So a person that needs a ride could just dial the phone number and say like, hi, come pick me up. So if they can't manage the smartphone piece, it's also a way to more easily set up rides for your loved one. So your daughter can call and say like, can set things up through GoGo Grandparent to say like, pick up my mom here. And it's supposed to be the driver has extra training into people with dementia. And I will tell you that GoGo Grandparent, it sort of has that same capacity as the same places that Lyft can do, but they basically add a surge charge to that service. So it is going to be a more expensive way to use those ride-hailing apps.
And then on again to a different topic, but is there a non-suicide option for ending one's life with dignity? Does dementia qualify for physician-assisted suicide?
Yeah, great question. In Washington, I feel like I can only really speak to Washington state laws, but in Washington state, people who have dementia are not able to participate in death with dignity. And the issue is really like it would be very rare for somebody with dementia to be able to do that. Again, you have to have the capacity to be sort of cleared that you don't have significant cognitive issues to go through it. And then, by the time people are, close enough to that 6-month window, then at that point, people just generally speaking, would definitely not have capacity if their life expectancy is that. The only exception would be for somebody with very, very early stage memory loss, Alzheimer's diagnosis, who has like a concurrent aggressive cancer diagnosis. That would be the only circumstances where it would be okay, but not because of the dementia itself in Washington state.
Well, this has just been a really helpful discussion, broad ranging. There's a lot more comments. Some of the specifics about OTs assessing driving and that sort of thing. But we're at 5:30, and so I think that if you have additional questions, let me know, and I can pass those on. And I look forward to seeing you next time. And thanks so much, everyone, for your participation. And Karen, what a great presentation. Thank you so
Thank
much.
you. Thank you so much. Appreciate everybody's time for being here.
All right, everyone. See you next week.